Welcome back to the Chatty Vets pod. I'm Brendan.
And I'm Charlotte. Thank you for tuning in.
Welcome back to the podcast. We've made it to March. The weather is slowly getting better and the days are a little bit longer. Spring is coming.
Yeah, it's nice to be getting towards a warmer weather and brighter days. And I live in Wales, so it's really nice that it's finally stopping raining. So it just makes everyone feel so much happier when the sun comes out and just a bit more positive, hey?
Yeah, you're in North Wales and that beautiful coastline.
It's gorgeous
Stunning.
and green, but
and
it's so
Snowdonia.
rainy.
Anyway, so to keep the positivity going, we've got a good show lined up today.
Yes, we're in the conversation a little bit later to get into some anaesthesia and analgesia protocols in our elective neuterings.
We'll also be discussing how to ace the vaccination consult and the latest vaccine guidelines from the RUSAVA, amongst other things.
And just in case you haven't seen on our socials, we've got some very exciting news for you. This month, we're not releasing the normal 3 episodes, we're releasing 4. Lucky you. So we'll do our normal 2 lots of 2-week takedowns, but this month we'll also be releasing an extra bonus episode at the end of the month to get you ready for that Easter break.
Forward to it. Now, before we get started with various topics, one thing that happened recently was that Cambridge Vet School is being kept open. Big news.
Yeah, really good news. I did hear about this. I think it was something like they'd initially made the decision to close the school after they were struggling to achieve or worried they weren't going to achieve the sort of recommendations that had been made to them by the RCVS, wasn't it? Because I think, didn't they get a visit by the accreditation team in 2024 or something? And they gave them loads of recommendations to say you need to meet this to stay accredited. But I mean, it sounds like they've managed to turn it around and they've said, yeah, great, we're going to stay open. So it's really, really good news for everyone involved. So
Oh, I hadn't heard that was the issue, but I don't know how many of these vet school university hospitals are financially not successful. You know, they're like in debt essentially. They don't make a profit. But I think Cambridge has definitely always had that issue, hasn't it? I don't think it's always been running at a loss. And I do think the university were looking at it and going, "What's this giving us? We're just putting money into this." So I don't know if there was a financial element too. Had you heard that?
Possibly. But I mean, anyway, it's great news to say that they are open. So yeah, that's really great news for everyone involved, and good news to start off the podcast with. So there we go.
We wanted to bring up a bit of a debate because this, I think, is happening up and down the country at the moment. Ovarectomies versus the kind of ovariohysterectomies, which we did traditionally, and also the traditional spays versus the lap spays, the keyhole spays.
Yeah, I think it's so clinic dependent, isn't it? What's going on at the moment? I think if you work somewhere that's more referrally, I get the feeling, or people were certificate holders or whatever in surgery, I feel like lap spays are definitely becoming more and more common. But I feel like correct me if I'm wrong, but I think the majority of GP practices, we're still doing typical midline incisions, aren't we? And doing a proper ovariohysterectomy in our bitches, and especially for cats as well, or your flank spays. And I don't know, I've never really had that much experience with, I mean, I've never done one. I've not been trained to do one, but I don't know that many vets that do lap spays. So I don't think it's still super commonplace in practice, but I know there's definitely a lot of people around that do them, but because we work in very different areas. So are you finding lap spays are far more common where you are?
Well, I've probably had about less than 5% of our clients, so maybe a few a year going off for lap spays the last 10 years. So they do it. And on my dog walks, you know, you'll bump into people who have the dogs had a lap spay. So I guess there's a run. And I talked to a new business owner about this, and he was saying that the cost of the kit is so high now that to make it financially viable for a practice is not easy. And you think what caseload you're getting through for lap spays.
Yeah, and we don't bring in any money from neuterings as well. I think that's the thing, is it, you know, in an ideal world, if we can reduce post-op pain, etc. for our patients, great. But also, we're already not making any money from our neuterings because you're having to competitively price them. So if you're then saying, okay, you've got to pay out to train all your vets to do them, you've then got to pay out for all the equipment to be able to do it, and pay all your nurses to learn how to clean and use all the kit. Like, it's a lot, isn't it? So I think unless you're a busy practice and you're doing at least 3-4 bitch spays a day, maybe every other day, unless you're doing them really often, you're probably not are you going to ever make that money back? But then maybe it's more worthwhile in those practices where you can do other things laparoscopically, and then the equipment's not just used for your neuters. Maybe they're the places that would be investing in it. But I don't know, I've always there's a paper that came up with some figures which we'll discuss in a second, but I feel like the biggest thing in people when you're recommending laparotomy versus proper abdominal incision is recovery time. time because of incision site. If you're making tiny little holes compared to one big hole to be able to visualize everything. And also potentially because you've got those smaller incisions, post-op infections, pain, etc. Not only that, but the aesthetic side of things. I always think in our patients, we've got such a range of size. If you're neutering, say, a female Great Dane, your midline incision to do an ovariohysterectomy is going to be quite big, right? Because you've got to be able to visualize everything. So you have to be able to get your hands in there, be able to get quite deep to be able to manually break down your suspensory ligaments, etc., and get everything out. So I think in those guys, yeah, you're definitely going to have much, much smaller incisions. So maybe their post-op recovery would be better. But if you were doing a cat, surely if you're making multiple holes for all your ports, because they're so small, is that going to be better? I don't know. I don't even know whether people have done them in cats or whether they would ever suggest it, or even small breed dogs. Like, where's the line? Where should we be recommending it, and where is it not a good idea? That's the thing that I find hard with it.
Well, yeah, it's not done in cats, is it? I don't think.
No.
And I think the whole thing about it is how the owner feels, isn't it? Because when you have your bitch home after the op, it's terrifying. Owners will, never forget how stressful it is. Their pets suddenly completely monged out, basically on opioids. They're whining, they're weird. Then don't owners have got an incredible? This is perfectly acceptable. Is they worry that the pet's going to jump on the sofa and they're going to rip all their stitches, or they're going to run up the stairs and all their stitches are going to tear. This is a huge stress point for owners, and also they can't get their pet out for walks for X number of days or whatever. And I think it's mostly motivated by clients having a faster recovery because, when I've seen the odd dog walker, they're on day 3 after the bitch spay and they're much more relaxed because there's much less to break down.
Yeah. I mean, the recent paper that came out last year by Moxon et al., they did a study. It was mostly retrospective data, and it was on about 519 bitches that were neutered in UK practices. And they compared peri-op and post-op complication rates in lap spay ovariectomies versus ovariohysterectomies via the normal traditional midline incision. And one of the things that I found really interesting, because it's what I found in practice, is that there doesn't seem to be any significant difference in the time taken to do the spays. So I don't think general anaesthetic wise there's much difference whatsoever, because the time it takes from when you get the patient into theatre and get all of the equipment set up for your lap spay to cutting is huge. Like, it's such a big time of like prep to get everything ready. And then, yeah, don't get me wrong, the actual surgery doesn't take very long because it's little incisions, quick whip the ovaries out and quick close them back up, fine. But so I think, yes, your ovariohysterectomy takes longer, but actually in terms of GA time, there's not really any difference, which is what they've said, which is quite interesting. So I guess in terms of anaesthesia, we don't have to be as worried. Yes, maybe analgesia a bit different, but anaesthesia, there's not huge amounts of difference.
Yeah, and the aftercare afterwards. I've watched Alan Van Heerden, who at in Greenwich doing a keyhole, and it was awesomely amazing. The amazing detail he's getting when he takes those ovaries out, because it's magnified on this huge screen. You kind of think, wow, okay, that's pretty cool. But yeah, the work involved is huge. But when are you finding you're doing ovariectomies in your routine surgery anyway for these?
No, to be honest, I still take everything. So I still take both cats and dogs. I still take the uterus. I'm not worried about leaving a little bit of uterus behind. So like often, especially for my cat spays, especially if I'm doing them flank, I often don't pull everything about so much that I put my ligatures around. I often do it around each horn rather than around the uterine body. So in theory, I'm doing half of an ovariohysterectomy because I'm not taking like the whole womb, because I find it's less traumatic, because it doesn't matter if I leave behind a little bit of womb. But I think as well, I'm just not confident in the technique for ovariectomy. I've never been taught it. I don't know how to do it. So I'm just going with what I know. But again, I think if we were in America, you'd be being taught ovariectomies rather than ovariohysterectomy. So maybe it'd be interesting to see if any new vet students are listening as well, to say like, are they being taught it now? And is it something that they're going to do when they go into practice? Because I still don't think it's translated to the UK really.
I've definitely made the transition a little bit. When you get a cat spay and
Mm.
the uterus is all spongy. So I had one of those, did the ovaries, and I thought, "Oh, I don't want to do that." And it was really thick. That was the other thing. I was trying to make a really little incision. So I made a really little flank incision. And I thought, oh, I'm going to have to make my incision bigger now because I've got this edematous, crunchy, massive, thick. So I just did the ovaries. But I was inside. I thought, I think this is okay. People do this in keyhole. It felt really weird because the very
Yeah.
first time I'd ever done it. And I dropped the two horns in, obviously with ligatures on or whatever.
Yeah.
But I felt like I cheated. But you imagine how much the little incision,
Mm.
no needing to deal with that crunchy edematous, kind of uterus.
Yeah.
It was a really good example of, why it's good to have that extra tip, trick up your sleeve.
Yeah. I mean, I think it definitely has its advantages, doesn't it? But with lap spays, especially, you need so much training and you need all the equipment, and it's a lot of investment with potentially not that much more return. I looked into this paper to say, are the post op complications and the peri op complications that we see, are they kind of worth it? Like, is it worth the investment? Because I was thinking if your complications are drastically reduced, then yeah, maybe it's something we should be investing in. So they said intra-op complications were roughly 2.3% for lap space and between 1.7 to 2.9% of normal space. Intra-op, it doesn't feel like it makes any difference in terms of complication rate, to be honest. Post-op complications prior to discharge were all similar, so all small. But they're saying that but more of your traditional ovariohysterectomies had more redness and swelling at the site compared to your lap space, which I guess makes sense for making bigger incisions and you're probably tugging on those incisions more where your hands are diving in. But then they said that the post-op complications is where the difference was. So post-op complications that needed veterinary attention were about 12.9% for your lap space, whereas it was all the way up to about 24% for normal space. They noticed fewer issues with inappetence, discomfort, licking or chewing of their body parts that were so those sort of what owners would say is a complication from surgery. They're still not right, we're not happy with them, they're not
I
back
get
to
it. So
normal.
pretty
Those sorts of
minor.
changes. I don't
Yeah.
think they were talking about eviscerating through wounds and things like that. They were talking about what owners would perceive to be something that they'd go back to the vet about, if that makes sense. But the only thing that I would say from that is the way that they collected the data as well. It was collected actively via forms like people filled in for ovariohysterectomy. So people had to actively opt in to giving them the data for ovariohysterectomy. But for your ovariectomy lap space, it was taken retrospectively from clinical records as well. So I guess you have to take in that bias of people may not have been wanting to be so forward-coming with the things that have gone wrong if they're having to openly fill in forms. So I don't know. I think this is still definitely up for debate as to whether it's something we should all be doing or whether it's something we should just be thinking about.
We had really positive feedback though but we had the lucky situation where we were sending to a top-notch laparoscopist
Mm,
and, they would, the owners were delighted. Like you say, they'd come, there's next to nothing in terms of their stress.
yeah.
And the recovery was so quick, they were exercising the dogs really quickly.
Mm,
I think they were allowed to exercise them from day 3 or 4, I don't know. And I don't
mm,
remember ever having any incision problems, though when I've worked in a practice that started it more recently, and they were getting a little bit of issues at the site where they were putting the little keyhole incisions, they were getting some discharge and some issues. So I guess there is a little bit of operator skill
yeah.
or whatever, or technique there.
Yeah. Yeah.
But
And I
it was
guess it
very
like
positively received.
yeah, and I guess it's who you're comparing as well, because say if you take us who have never done lap space before, we're probably going to get a higher complication rate if we were to start doing lap space than if we just do our normal ovariohysterectomies, because we've been doing our ovariohysterectomies for years with no problems or few problems, and then you go to do something new, you're going to get more complications. It's like comparing a new grad vet surgery compared to someone who's been qualified 20 years. Like they're going to get more complications because they're newer, they're going to cause more tissue damage because they're not so used to it. I think it's more like it's whether it's worth the investment into the equipment and the time to train your staff. Like which patients should we be using this for as well? Is it only your large breeds? Is it over 10 kilos? When are we recommending it? So I think there's just a lot of discussion that needs to be had about it, really, isn't there?
I think the more interesting thing and more current thing at the moment is us guys doing ovarectomies instead of ovariohysterectomies in our traditional surgery. To some extent, it's hard to argue with the rationale of why especially if it takes us extra time, why we take the womb out.
yeah, it'd be really interesting to see how many people that are listening do them. Because if anybody is just doing ovariectomies, have you found much difference? Are you making smaller incisions? What have you found in terms of recovery rates, etc.? I wonder if they're a lot less painful as well. Maybe, but then is it the suspensory ligament that's making them more painful? In which case, is removing the ovaries the thing? Are they still going to be just as painful anyway? I don't know. So it's just interesting to think about, isn't it?
Well, yeah, I'm not sure it makes that much difference overall, but your incision can be a little bit smaller because you can kind of
Mm.
you're more neatly where the ovaries are. You don't have to extend caudally. Yeah, a conceptual change. Yeah, let's see where it goes. I can't help thinking it's going to become more and more common.
I wonder if we have this discussion in another 5 years' time, whether it will be really different and it will be what everyone's doing. So it's just interesting, isn't it?
On the topic of things we've always done, flank spay versus midline spay, because this is
Yeah.
very UK centric. Because everywhere else in the world, they're like, "What's this flank
Yeah.
spay?"
Yeah. I know.
So,
To be fair, I'm one that I
yeah.
give my clients the option. I think subjectively, if you do flank spay, for me, my cats get less seroma formation. They're back on their feet quicker. They're less painful, I feel, versus my midline spays. I tend to find if I'm going to get complications, I get more complications midline. But then equally, I put it to the owner and say, if something goes wrong in surgery and there's a bleed, I'll have to flip them on their back and make another incision to be able to fix it. So I put that to them and then they can make up their mind. And I think that's quite nice. But I think a lot of vets just have one or the other they prefer, don't they? But I don't know. I think flanks definitely have a place. I really like them. But have you ever had one where it's so annoying where you make your incision and you're like, where the bloody hell is it? You know, you're like fishing around for ages and you're like,
On a
it should
flank
be
or
here.
midline?
Yeah, on a flank. Midline's fine, isn't it? It's like always there. But like flank, you know, and you got your spay hook in and you're like, for God's sake, where's the bastard thing? And you just can't find it for ages. It takes forever sometimes, doesn't it?
Yeah, it's. I have this with my toolbox or various things like that as well. Where when you drop something and you want to find it, don't like mess it all up. And
Yeah.
the abdomen's like that, isn't it? On a flank.
Yeah.
Whatever you do, don't start getting everything out and jigging it all
Yeah.
around because you'll never find it. You just
Yeah.
got to like try and leave things where they are.
Yeah.
What's your? Well, you know when you're talking to like a newer vet like about how to do it.
Yeah.
Do you look for the shiny fat and go underneath that? What's your little
Yeah, the more
tips for?
yellowish stuff. And then I'm like, if you can't find it, don't panic. Put your spay hook down, put your hands on the drape, jiggle them a little bit, and then try again. I mean, I'm not saying like shake the patient, but sometimes where you just need like a little jiggle for everything to settle again properly. And then when you have another fish around, you're like, oh, it's there. So
I don't
yeah,
use the
that
spay
sometimes
hooks.
helps.
I don't. I'm too clumsy to use a spay hook because you know how you put the one or two times I've done it, I put it in and then I panic and I try and pull it out and it's grabbed hold of something
Yeah.
and I think, oh my god, I'm going to tear something. I hate the thing, so can't use them.
Yeah.
So I just go, yeah, I look for the shiny fat and try and pull that caudally on the flank spay and kind of just look behind it, I suppose. Seromas in midline cat spays, maybe, look, and you sound like you do a few, but if there's someone who does lots and lots, which probably there is, especially internationally, is there a way you can do it without getting a bit of seroma there? Is it just inexperience because we're not doing enough of them? I'd love
Mm.
to find out because
I
have you,
wonder
yeah.
whether I wonder whether part of it is I think, you know, when like at vet school, I was always taught undermine the fat so that you can see the muscle layer so that when you stitch up your rectus sheath, you can see exactly what you're doing and you're not taking a bite of your subcut fat at the same time as your rectus, so it's stronger, right? But I think a lot of the time, I mean, cats are tiny and you think everything's so fragile. I wonder if a lot of the time we're just undermining too much, we're causing too much tissue trauma, and we've just got that dead space, and that's where it's come from.
So when I was a new grad, I did exactly what you described. I think I was like, right, I'm going to do this really well, and I dissected exactly what you said. I think it was a bitch. I don't know. I can't remember. But I dissected it back really neatly, quite a bit, and got it all tidy, stitched up everything. Got a seroma, and it wasn't a cat, it was a dog. So
Mm.
exactly what you're saying. So maybe that is it.
And I think
Yeah.
sometimes they're just going to get one, aren't they? But I think, you know, if we can prevent our tissue trauma as much as we can, use those good old house dead principles, then I think that would be really good. So we've chatted about a little bit about one of the surgeries we do really routinely in general practice and how we can possibly be thinking about our surgical options with bitch spays and what might be best for our patients. But what about our routine analgesia and anaesthesia plans for these patients? So take our routine ovariohysterectomy, dogs and cats. Brendan, what do you find your normal analgesia anesthesia protocol is for these patients. So what's your sort of standard that you do most of the time from pre-med to induction and maintenance?
I think it is the UK standard the last few years. Medetomidine, lowish dose. My dose might be a little bit more generous sometimes. So it'll be 5 mics per kilo, but I'll go up to 10 mics per kilo if the dog is, how do we put this? Very difficult to handle, let's say. So yeah, plus mostly methadone, obviously. And then my dosage, do you know, I've always ummed and ahed about point 0.2, point 0.3, whatever. And so I've just gone 0.25 mg per kg methadone. And I could make a good case for doing point 0.3, it's fair. But I've had the odd one, a little bit nauseous, post-operatively. And I've thought, "Do you know what? And when you've done they vary quite a lot, don't they? Some of them don't feel like you've put the bitch, there's no bitch has gone through that much. Like I don't know, a cockapoo or something, it's not
Mm,
that much pulling and tearing. It's not too bad. And then they're all like drooly and nauseous. So
yeah.
yeah, so that's that, and then IV cannula, propofol induction, and
Yeah,
yeah,
I think I'm the
yeah,
same for
yes,
you. I think to be honest, I'm a zero point 0.3 mg per kg methadone person. To be honest, if I'm doing a hysterectomy in cats or dogs, and if I find that they're post-op nauseous, I just give them Prevamax, because I think sometimes you're like, are they nauseous because of the pain, or are they nauseous because of the drugs? I'm never quite sure. So it's that
it's the
question, isn't
drugs.
it? Yeah,
I think it is the drugs mostly, only
yeah,
because seeing the transition. I remember when Comfortan came out. So prior to that, it was Vetigesia, buprenorphine was the number one,
mm,
and we definitely saw an increase in nausea when that drug
really,
came out.
yeah,
Because it was one of the most critical things about what staff felt about the transition.
mm,
Um, I don't know. Maybe I'm missed. It's hard to know for sure, isn't it? But I do
yeah.
remember staff complaining about nausea as a side effect.
I think there's no debate anymore as to whether buprenorphine or methadone is the right thing to use. I think 100% we should all be using methadone, shouldn't we? But it's one of those things, like you say, you've got panting that you need to worry about, and if you're worried about nausea as well, it's like, what is the right dose?
I don't know why it's so different internationally, but they don't seem to use methadone in nearly the same frequency in North America or
Yeah,
other
maybe.
countries. Is that right? And they're going to use
Yeah.
hydromorphone.
From one of the charity practices that I've worked in, they don't have methadone. I think costs are so limited, they just find buprenorphine is the thing that they have. So I use a lot more local anesthetic in that place because lidocaine's so cheap. But I always find recovery, because I'm the same surgeon doing the same surgery in those places compared to everywhere else. But buprenorphine versus methadone, oh my God, there's a massive difference. Absolutely massive. Like the bitch pays that I recover in from methadone in normal practices do really well. And the buprenorphine ones, I'm always like, oh, you look really sad. And I don't have IV paracetamol that I can use for them in those clinics either. So I try and load them with as much as you can. But with charity, you're a little bit more limited, aren't you? But anyway.
And I feel like we need to do a better job of just going on to hydromorphone and morphine in North America. It's 5 times as potent as morphine and causes less
Yeah.
vomiting. 'Cause I know we got like 10% of our audience is beyond the UK, where methadone, I think, is getting more and more popular. And I think maybe in Canada it's coming out. And I certainly feel like I'm seeing that on my American vet group. But I think they're mostly hydromorphone and maybe even morphine. But it seems like methadone is, yeah, it's a bit of a UK thing, but it's a good thing. Yeah, everything's got pros and cons, isn't it? The pants, and like you say, the pants. I think the nausea is just always going to be a problem with mu receptor antagonists.
Okay, so you're using in obviously we practice in the UK, so you're using methadone, medetomidine as your pre-med, you're inducing with propofol, you're maintaining with ISO and oxygen. So in dogs, are you using IV paracetamol in these patients? Are you giving NSAIDs to dogs and cats? Are you topping up with ketamine? Like, what other analgesics are you using for these patients routinely?
Yeah, so I haven't come across using IV paracetamol for bitch sprays until we both work at practice where they do it. And I thought, what a great idea. Why hadn't I thought of it? I was like kicking
Mm.
myself that I've been practicing for so long, and yeah, I'm using IV paracetamol in all my like GI surgeries and everything else. Why the heck wasn't I using it in the bitch space? But then I suppose maybe it was a cost thing. But in fairness, that bottle of paracetamol, IV paracetamol, I don't think is that bad if you use it.
I love IV paracetamol. I use it every day. I think, like the other day, I had a bitch spay and a dog castrate, and I was like, well, I'm opening the bottle for the bitch spay, so I'm just going to use it for the dog castrate as well. And I might change my doses. I might go 20 mg per kg IV for the bitch spay, but I might go 10 mg per kg IV for the dog castrate because I don't see them to be so painful. Maybe that's coming from a female point of view as well. I don't know, but I think it's the size of incision and all that sort of stuff. But it's,
You've never been kicked in the balls.
no, no. So, but yeah, I think there's definitely an argument for using it. Obviously not in cats. Please avoid it in cats. But yeah,
Yes.
I think IV paracetamol, 100%. NSAIDs, I think we had this debate a little while ago where we were talking about, you're like me, you like to use it in recovery, don't you? Or at the end of the op because you want to know what's going on with the blood pressure. But I think we're both on the same page that you're using NSAIDs routinely in these elective surgeries, aren't you? So if you're for any neuter, you're considering using it generally.
Yeah, NSAIDs all the way, obviously, but yeah, inject once I feel like the threat of hypertension has
Yeah.
passed.
If you get some sort of breakthrough pain in surgery, what do you use? So say you've given your paracetamol, you've already given your methadone and your medetomidine, which has some analgesic properties anyway. It's under anaesthetic, you've propofol it, blah, blah, blah. What are you using if you think you're getting breakthrough pain? So what's your first go-to if you think that they're uncomfortable?
I'm trying to get better, and sometimes I do have to say to the nurse, "Can you remind me about my local anaesthetic?" Because I'll
Yeah.
forget. Because I do think it's a good thing. It's just, it just takes time, doesn't it, to
Mm,
incorporate something new into your thing. But I do like it. I use so lidocaine splash block. Obviously, it's immediately acting, and I can put it on my ovarian pedicle. And maybe I think it does have a little effect. I splash a little bit on, and then lidocaine seems like the optimum thing for that. But if I was like being super luxury, I'd then also have my um, bupivacaine for my longer lasting pain relief, which I would then do into my muscle and skin layers for closure. And then I've got both. I've got the ovaries kind of slightly dealt with for that pulling part, and longer term local for my muscle
yeah.
closure and skin closure. How about you?
If you're using both, are you using, because I've never used the both together, what do you do with dosing? Do you know? Do you just half dose both, or what do you do for dosing?
I haven't got that far in thinking about it because that was only my ideal thought. Because in my
Fine.
head, I've always got this, yeah, I've always got this contradiction in my head. Kind
Yeah.
of like, what do I do? Do I want 1 hour right now, or do I want several hours? And so in
Mm,
my head, so I just said that out loud. I've
yeah.
not done it. That's a really good point. You'd have to split. Yeah, ooh, we need someone. We need. Oh, okay. We need people with more anesthesia knowledge than us to
Yeah,
discuss this.
exactly what your dose could be. Yeah. So, yeah, I think so my dog castrates, I intratesticular lidocaine, like halfway through scrubbing. So once they're cleaned, I put the lidocaine into the testicles, and I think it makes so much difference. Normally if you do like a closed castrate and you strip the fascia, you've got your cord and everything in front of you, and then you go to clamp it and it does that like thing. It like contracts away from you because you can tell that they're feeling it when you clamp it. Whereas if you've lidocained them, they don't move. And I'm like, that's so nice. They can't feel
Clever.
me
I
clamping their
never
ball.
noticed that. Yeah.
No, it's like
Right.
fun that the
No, I
muscle
like
goes
it.
like,
That's a good one.
and it just shows that it's
Okay.
worked. So it makes me feel better. But
Right, about 12, I don't know, I haven't looked at the dosage for this stuff for ages, but when we first started bringing this in, which was like 2013 or whatever,
mm,
the dosage for the intratesticular lidocaine was huge. And I
mm,
remember we all looked at it and thought, and we were already like putting a needle into the testicle, but then injecting that huge volume seemed way too much. And I
yeah,
think my colleague just started injecting like a third of the dose, which is like a very sensible solution.
yeah.
But yeah, have you got a dosage for your testicles?
I just go 4 mg per kg because 4 mg per kg is the normal local dose. So that's what I use. And it maybe,
And it
yeah.
works.
Yeah, but I think as well, it's patient size dependent, isn't it? Because you're putting a larger volume into larger testicles. So I don't know, for me, it kind of feels
Well,
okay.
is it patient size or is it testicle size?
Well,
Because I just say to the
yeah,
nurse,
true.
we should be weighing the
Yeah,
testicles.
yeah, true.
But do you know, I did read recently that because you know how you inject it in and you feel it getting plumper as you put the
Yeah, yeah,
local
yeah.
in. Just exactly what I said, because it's not a dosage, is it? It's filling up all the little tubules to the
Mm,
point where a bit of local then goes up the cord to where
mm,
you're ligating. So you
yeah,
just need to get enough to get you into there. So the tension on the testicle is a good reflection that you've got enough in. Because
yeah,
once it's tense enough, you know local's going to be going to the somatic cord where and the bit where you're ligating.
yeah.
So now I do to some extent. I've got like a top amount in mind, but I will inject to some extent till I get enough tension, and
Mm,
then I'll stop.
yeah.
And I think that is another way to dose. these.
Yeah. I mean, I find that intratesticular lidocaine for me works really well. I find they recover really well. The surgery goes really smoothly. I don't get a spike in heart rate when I clamp the testicles, etc. I do think one thing I need to get better at is, like you say, splash blocking my ovarian pedicles. I find it really faffy, like making all the local sterile so that I can use it mid-surgery. So I end up, I know that sounds really funny, but what I normally do is I normally do the surgery and literally just as I've closed, I do my lidocaine, I inject it subcut around the wound so that I feel like they're comfortable on recovery. But I appreciate, because it helps with their wound. It doesn't help with the abdominal pain, but it helps with the wound pain. But I think I do need to get better at like being more asked to to like do it sterilely so that I can use it intra-op as well. Because I do think those splash blocks on the pedicles do make a difference, both intra-op and afterwards. Because I think they must be painful abdominally, have that deep pain afterwards. So I think I probably should be doing it. It's something I need to get better at, really. But
This might be something I'm doing that's bad, but I think I like to get the nurse to draw up the lidocaine,
yeah,
and I will like go, "Here's my ligament, could you splash a bit there, please?" And
yeah.
she kind of splashes a bit on the pedicle,
Yeah, I think it's
so
I
I
think
don't
you
have to be faffy and get it out.
yeah,
Is that
I think you can do
acceptable?
that way, but I think I'm just too paranoid. We shouldn't be leaning over a sterile site if you're not sterile, should you? But then it's like anything, isn't it? I mean, sometimes we have the aircon or the heating on or whatever to help with the patient's temperature, and you're like, well, there's going to be hair floating around because you've got that on, so nothing's perfect, is it? I think what we should be doing is drawing it up sterilely, having it on our table, like our instrument table, and using it ourselves. But again, when you've got like a massive throughput of cases and you're just trying to get done, it's hard to sometimes remind yourself to do it before you scrub up, isn't it? So okay, we've that's a bit about local, but what about ketamine? Are you ever using it as a bit of a top up analgesia for these patients?
I'd love to look really clever and say I was, because I think it's a great idea, but I haven't.
Do you know what? I've actually started using it really quite regularly because when you're doing a bitch spay, and especially those like little dogs where they're just really panty and huffy and they won't settle. Previously, I was like, oh, give a little bit more medetomidine, or if I hadn't given the paracetamol already, I'd give that and see what happens. If I'd only given 0.2 mg per kg methadone, I'd say like give another zero point 0.1 and see what happens. But now I'm a massive ketamine convert. I love it, literally love it. So if I ever find that they're just not quite settling, and I think maybe it's because 'cause they're a bit painful, they're just a bit reactive, I'm having to keep them on, like, a little bit more ISO than I'd like, because I like them on, like, 1.5, 1, and if I'm having to push up to 2, I'm thinking, "I don't like that, I don't like the percentage being that high, I like them coming a bit lower." So, especially for our hypotension and stuff, I wanna try and avoid it. So, I actually give them I think the doses, correct me if I'm wrong, but I think it's 250 to 500 micrograms per kilo as a bolus. And I tell my nurse to do that on her calculator because I can't do that in my brain. And then I'm like, "Oh, give that
That
much." And
by the way, can we have you saying, "I'm a massive ketamine convert," as a, like,
yeah,
a video clip at the front of on our website?
yeah. Well, it's
Can
true. I
can you
love it.
honestly do that? That'd be brilliant.
I mean, well, do you know what? No, I mean, maybe this is a story for another day, but actually, maybe I shouldn't say that because I did have the police call me
Oh,
once about
no,
using
go on.
ketamine in a case, so they're going to be after me now. Basically, long story short, I used some out of date ketamine to anaesthetize. Well, no, to basically anaesthetize a really aggressive dog that I needed to put to sleep because it was the only bottle of ketamine we had left in stock, and it was a
Yeah,
practice where like we didn't really have many sedatives, so I used Domtorb and Ket to IM this dog, but it was at the point
go
the
on.
owners couldn't get near it. I had to like dog catch pole it, push it to the floor and jab it in the bum. It was
Wow.
horrible to even be able to muzzle it, to be able to get near it, to euthanize it. Like I'd poured some Pentaject in a bottle to try and get it in a bowl to get it eating. It was really bad. I couldn't get, anyway, long story short,
Wow.
I'd used out of date stuff. I'd recorded it in the book, but the police called me and basically told me that I'd done something wrong. And it was
No.
this was like a year and a half after I'd done it. They called me and said, "Do you remember using out of date ketamine in this case?" And I was like, "Oh my God, what have I done?" And then I remembered and thought, well, yeah, I did because it was the only thing in stock and human safety was at risk. Like any other vet would have done the same thing. And anyway, he told me he was going to report me to the RCVS because he said
What?
it's against your code of conduct. You can't use out of date drugs, blah, blah, blah. So I'm assuming he reported it to the RCVS and they turned around and were like, we're not going to, we're not going to do anything about that. She did what any other vet would have done. But yeah, like shit me up for weeks. I couldn't
Jesus.
sleep. I was like, I'm going to lose my license. Anyway, that's my ketamine story. I just find like any surgery where I just find they just need a bit of top up. I really like it. And honestly, it's sometimes you're giving like 0.03 mil and you're like, is that going to make any difference? But honestly, Works a dream. Love it.
So,
So
to talk
good.
about tagline for the episode, massive ketamine
Mm.
convert. But
Cool. Okay.
yeah.
Yeah.
Um, so hold on, let me get this dosage right, because obviously 1 mg per kg will be easy, because 1 mg per
Mm.
kg. So for a 10 kilo dog, that's 10 mgs. It's 0.1 mils. So you're doing half of that. So
So I'm
max.
doing
So yeah, zero point zero
no. So
0.05 for a
I'm doing
10 kilo dog.
no. I'm going 250 micrograms per kilo.
Well, you're going
Is that
250
right?
to 500, did you say? Because I was going off the top end.
Yes.
But yeah, you could do a course. So you're
Yeah.
doing 0.25 to 0.05
Yes,
mils of
but I think that's why I
ketamine.
have to divide it by 1,000 first, because I feel like I'm a bit, I can't remember what it's called, but I feel like I'm a bit like number dyslexic, you know, when you can't work out where the decimal points are in your head. So I have to divide it every time so that I get it right. Because
Hold
anyway,
on.
but that's a me thing.
This will be, that recording will be in your statement when they take you to court for getting a dose wrong. And you, there she is saying it on a podcast live. It's
But yeah,
true.
but
Yeah,
yeah,
you'll have
it's,
no
and I,
defense there.
yeah, but to be honest, I normally start with the 250 micrograms per kilo, because I find that if it doesn't work well enough, I can top it up. But half the time, like the majority of the time, I find it does. And like I don't want to use a lot of ketamine because I find they have a bit of a dysphoric recovery and stuff. So you don't want to use a lot. But I just find that little smidge can really smooth things out. It just makes a massive difference. So yeah, big convert. I like it a lot.
Okay,
So
you could do my little trick, which do you do this trick with the medetomidine for the, if you get a difficult recovery, you want to give them a little smidge of medetomidine.
mm,
And this has come from years back when I used to work with anaesthetists, and they used to tell me to get 0.1 mils in a 1 mil syringe, top it up with some saline or Hartmann's. So you've now
mm,
diluted it tenfold, essentially. So you've got
mm,
a mil syringe full, but it's only got 0.1 mils of medetomidine in, and then give little aliquots, little 0.2 mils IV,
yeah.
and give it a few minutes, give it another zero point 0.2. I find I nearly always
Mm,
need at least 2 of those to even get started,
yeah.
but just to smooth the recovery. But you could do some, do you do, I don't, number one, do you do something like that for medetomidine on recoveries? And number
Yeah.
two, could you do that with the ketamine in drop? Same kind of deal.
Yeah, maybe. I've definitely got into the practice of the majority of my patients, I don't give them Atipam. I leave them 10 minutes when they're off the ISO, I leave them 10, 15 minutes on oxygen and see whether they recover on their own, because I find the majority of them recover so much nicer with that DOM still on board, and they'll still recover nicely without the Atipam. But if I give them Atipam, that's when they throw themselves around. And then I'm worried about, okay, well, can I top them up with medetomidine because I've already given Atipam? Do you see what I mean? So to be honest, I leave them to recover without Atipam a lot of the time now. And then I just top up the DOM if I need to. But I still definitely use medetomidine in that kind of way during surgery. So if I've given a really low dose as my pre-med, and especially if I've given it IV, if I then start the op and I think, oh, that's not worked very well, sometimes you don't feel like you need the same amount again, but you want kind of the same amount. So what I'll say to my nurses, again, draw up the same as my pre-med dose, but dilute it, mix it, and then give like a quarter of that and then see how we get on. And then we can give another quarter if we need to. So yeah, same principle, but I actually do that intra-op sometimes. So, but yeah, there we go. So,
So, right, two things spring to mind. One is, well, mostly about blood pressure here with these two
mm,
drugs. And I think it gets a bit, can get a little bit geeky and technical, but I'm assuming here, obviously, ketamine feels like you might be really helping the blood pressure. Is that how you, what the measurements come out
yeah.
like when you're doing this?
I'm not I'm not sure if I'm helping it, but I definitely don't see the drops. So whenever I've done it, so previously when I was always topping up with medetomidine as my first line, like blood pressure would always tank. Same with, you'd always get bradycardia as well, which, you know, if they're a young, fit, healthy dog, you don't have to worry too much. You just keep an eye on and you just reduce your ISO rate. But I definitely find that it helps me to keep the blood pressure better if I use more ket than medetomidine anyway.
Or
So
turning the
yeah,
dial up on your isoflow, because turn it even 0.5% on
yeah,
your isoflow, I feel like that is a linear graph. Your blood pressure is
yeah.
going to drop by 10
It
to 20
tanks
or
it.
whatever.
Yeah,
Yeah.
100%. Yeah. Yeah, it really tanks it. So, but yeah, there we go. So I'm, like you say, I'm a big
Um,
convert. I use it all the time.
Medetomidine and blood pressure. Now, it's been years since I kind of got, I used to be a bit into this, and to be honest, I haven't really
Mm.
got into anesthesia the last 10 years. But so, medetomidine, it's peripheral vasoconstriction. And people say that for the first 45 minutes or whatever, you might get hypertension recorded on your measuring devices.
Mm.
And then it's only after that that you might start to see other effects predominating and you start getting lower blood pressure. Do you actually find, because it's isoflow sparing, the net effect is very positive again?
Yeah, I mean, I find generally if I've given my patients a good amount of medetomidine, I can normally keep them on 1% easily and they're pretty steady. And I do still find that their blood pressure's still on the lower end compared to if I've used the lower DOM dose.
Do you know what? I'm also a little bit in what the nurse is used to. If that
Yeah.
nurse is used to that protocol and that's how she
Mm,
does it, I'd rather not push her outside of her comfort zone because I'm busy doing my bit. You do your bit that you're familiar with because in your
mm.
hands, I think generally that can go better.
Yeah. And also, I don't know about you, but locuming, I found I've been to some places before where I walk in, the nurse has admitted the patient and they've worked out the pre-med dose for me. And I'm like, I don't, it makes me panic. I don't know why, because it's not that I don't trust them, but it's more of a, oh God, I've not done it. I feel like I need to check it because, when it's like that, it's something I've always done. And I've assessed the patient and I've been like, well, are they anxious? Are they bouncy? Like, how much do I want to give them? Am I going to give it IV because I'm going to get a catheter in when they're conscious? Or am I going to give it IM because they're too bouncy to get an IV in? Like, they're the questions that I'm asking in my head. And I change my pre-med dose all the time, depending on the patient. Whereas I think some practices just have a protocol of what they use unless they're really sick, in which case they'll ask the vets. But it makes me really nervous. I'm always like, oh God, please don't do that. Can you leave it so that I can work it out? And it's not because I don't trust them. It's just that in my head, because I've always done it, I feel like for me to be confident with my anaesthetic, I have to do it myself. Have you found that or not?
I love what you're discussing because it's brilliant. So we've got an issue here, haven't we? Because I think there's some really big gains to be had by having a practice pre-med protocol that is
Mm,
used all the time. Because then all your team of nurses all get experienced at that protocol, the pros and cons of it, how we deal with it. If you get breakthrough, blah blah, then you give this, then you give that. I think when a nursing team has a really good practice policy, let's call it, I think that's a really powerful tool for success in a practice. And if you have every
mm.
vet doing something different, I think that's hard for the nursing team. They will eventually
Yeah,
get used to everyone's different ways, but I do think that's a potential for causing stress and problems. However,
yeah,
also on that, I'm like you. If someone asks me what pre-med dose I want, I cannot just look at the weight and give them it. I have
no,
to literally, I'll have a flick through the history. I will go and have a look at my patient and I want to feel for what that animal is like. I want to look it in the eyes and in a way, and not freak it out. I'm not literally looking
mm,
in the eyes, but I just want to see how its vibe and how it's reacting to things. Because like you, I'm going to adjust my metatomidine according to
yeah.
how much the patient needs. Because ultimately, I want enough metatomidine to be able to get the IV cannula in without upsetting my patient. And that is dose dependent, I think, on and
Yeah. And
anxiety dependent.
I think like practice protocols are great, but every patient is so different. You're going to have the really chilled out Labrador that's like, yeah, have my leg, do what you want, really not bothered. Whereas you're going to have like the absolutely mental spaniel that will not stay still and is like, please don't touch me, please don't touch me. So it's very patient dependent, isn't it? And the ones that you can catheterize and you're not going to freak them out and not going to stress them, great, get an IV in. But the ones that you're going to really freak them out by trying to get one in, I just IM them because it's easier and it's nicer for them. So, yeah. But anyway, so we didn't want to stick to elective surgeries for the whole episode today, but we wanted to stick a little bit on the analgesia theme for a little while. And it seems to me that there's more of an emerging sort of group of people that are using subcut ketamine in chronic pain patients in the veterinary world. Now, I know I've definitely seen a lot of people use it for OA patients, but is this something that you've seen used, Brendan? Are you using it at all in any of your patients?
Well, yes, I'm seeing it used, definitely. I feel a bit reluctant. I'd love to see a published study about this, but yeah, maybe I should be there. At the moment, Librella's kind of just like filling that hole, I suppose.
Yeah. I mean, I think the only sort of, it's not even evidence, but anecdotally, the only thing that I would say is there's quite a few patients at the practice that I work at the moment where another vet has started them on long term ketamine, every so often. And the owner's perception is that it's made an amazing difference, that it's made them so much more comfortable and they can really tell when it's wearing off and when they need another injection. So I find it really interesting because it's initially when it first started being talked about, I was like, well, what dose do you use and how often do you give it and how does it work? And like, is it not going to make them sleepy or ataxic or I don't, actually the patients where I've actually seen it used in practice, it makes a massive difference. And I always forget to talk to owners about it, but I do think it's something we should be discussing. But have you seen much about the stuff that they cover on the zero pain philosophy and all that sort of stuff?
Yeah, I know. I hear it. I read it. Yeah, I just feel like,
Mm.
be honest. Are you being sponsored by ketamine?
No, no. And it sounds like I really love it, which I do, but not for
You
me.
really do love it. Well, like a lot of stuff in our world, it gets to be a momentum about something. And then once enough
Mm,
people are using it, enough people have started using it, then you go, all right. Then you look around, oh, they're doing it and they're doing it. Okay, I'll give it a go.
mm,
And I think because it feels a bit dodgy because I don't know, maybe there must be, I assume there's some publication about it, but it does seem a little bit homeopathic kind of.
yeah.
Well, it's the wrong word, really, in fairness. Or maybe it seems too good to be true that a little subcut ketamine can make such a profound effect for 4 weeks.
Yeah. I mean,
Yeah.
I think from what I've read, and again, I don't think it's papers, it's just what's been written by some people that have said that they think it really helps, is generally if you're looking to use it for chronic pain, you want to go for a zero point 0.5 milligram per kilo dose and you're giving it subcut. And they basically said it's still up in the air as to how often you give it. Like in those real chronic pain patients where you think they're really painful and they're already on quite a lot of medications, you'd maybe use it once a week. But for some patients who have more milder pain, which I'm not really sure which ones I'd be using that in, but in a more mild pain situations, so maybe you could give it every 4 weeks, similar to how you'd give Librela or, your off license Cartrofen and things like that. So I think that there's definitely a place for it. And to be honest, the patients I have seen it used, it's been once weekly, but they do find it makes a massive difference. So I don't know. But then even in my notes, reading from where we've got this information from, they literally say we have little evidence beyond such as anecdotal, and it's important to be clear on that. So we are
Oh,
literally saying that we think this works because we have a very limited evidence base from it, but from what owners have perceived and what we've perceived, it seems to help. And ultimately, to be honest, for me, I don't know, the patients that I'd be using it in are probably your end stage arthritic patients anyway, who don't have that much longer to live and it's all about a quality of life. So I'm a bit like, do I really care about the evidence? If it helps, it helps. Like, how much harm is it going to do in those patients? I don't know. And it's not something I'd be using in like a 4-year-old dog, but if it's like a 13.5-year-old Labrador that's struggling to walk at all, then great, give it some ketamine, make it feel better.
are winning me over actually, and I think hearing you, I know people do it. It's probably not. Do you know things have to get into your brain at the right the right moment in the
Mm.
consult for you to remember to do it? And
Yeah,
you're right because I probably the time we see it often is nowadays we're getting the Librela case and it's been on Librela for a year and now it's not working in the same way as it used to.
yeah,
I could be just like you. So that old dog, it's on NSAID, it's on Librela, it's on, and now it's not like it was a year ago. Yeah, maybe that's quite a good opportunity, and I'm missing it. What about the amantadine versus ketamine subcut? Is there an option? Because only some of my patients will be on amantadine by mouth. Is this kind of a
yeah.
similar mechanism?
Being completely honest with you, I don't remember that much about amantadine and I hardly ever use it. I see quite a few patients on it. This is really bad. But and it's
Yeah,
just,
no.
when you get used to the drugs that you use and you're just a bit like, it's just
Oh
not
God,
one that I
no.
really ever prescribe.
Look, yeah. I'm getting Gemini up because I was on Claude and it's shit actually. So I'm going to Gemini. But I feel like amantadine might be an NMDA antagonist too. So it's similar
Maybe.
receptors, but it's as a tablet and it feels a bit more legitimate. I don't know.
Yeah. So does that mean that you can't use the amantadine and the ketamine in the same patients, or can you use the two together?
Oh, true. Probably. Well, look, it's such a low dose of ketamine. Who cares? But you
Yeah.
might say, "Oh, are you getting?" Maybe you're going. Yeah, are you getting side effects?
Yeah.
But yeah, here we are. I've typed in amantadine PO versus ketamine subcut for chronic pain in dogs with joint disease. Yeah, they're both NMDA antagonists, so they're
Hmm.
similar receptors. Yeah, I think it's a valid thing to bring up in the discussion because it's the same receptor, but it's a tablet. So,
Mm.
yeah.
Yeah.
Do you know what? This point where tramadol was all the rage and then it wasn't, and I
Mm.
suppose gabapentin. But there's, sometimes with me, I make the mistake sometimes of getting the absolute worst case for the new drugs, not seeing much of an
Mm.
improvement, and then going, well, that's not much. And I think I've done that with
Yeah.
amantadine. And maybe now you're saying this about, blocking NMDA receptors has some, benefit. If this ketamine, maybe you could make a case for amantadine.
Yeah, yeah. I mean, if anybody does regularly use it in their OA patients, then let us know
Uh,
in terms of subcut ketamine versus amantadine, whether you think one works better than the other, whether you do use it in the same cases, then let us know because we're obviously not routinely doing it. But I think subcut ketamine is definitely something that I I might be trying in the future because I think it really can work. So, and I think as long as, like with anything, if we're just being really honest with owners and saying, look, there's not much evidence, but anecdotally we found that it really helps, I think most people will still be like, yeah, cool, give it a go. I guess moving on a little bit from anesthesia and analgesia now to something else that we do every day, but something that we don't feel like we've always done that right, the vaccination consult. Now, I think it sounds like something really boring to talk about because it's just something we get taught at vet school, and I think everyone just goes into it on day one, and it's what you're doing in your consult room as a new grad from day one, isn't it? It's like, I guess, deemed to be the easiest thing for us to do. But actually, I think it's actually really underrated how people view them. And sometimes I think revisiting the hints and tips that other people have in terms of how they do their vaccine consults and what makes a good vaccine consult can be really good. It's how we gain a lot of trust from our clients. So, and I know, Brendan, you're one for taking a long time with your clients and really sort of chatting to them. So, I mean, like, what do you do in your vaccine consults? Because I feel like you're in there with them for hours.
God, do we have to have? I feel like I need to apologize to everyone I work with, and no, I'm so sorry. Yeah, it's true. I'm rubbish.
No,
Yeah,
you're
I
not rubbish,
do.
but clients love it
What?
and they feel
Why?
like they're getting a really good service. But I just mean, like, what
I'm
do you
really
discuss? Because
passionate.
yeah, you
I
take a while
do.
with them, but I like it.
So embarrassing. It's awful. People hate me. Like receptionists, poor things. They want to go home. They have a life, but I'm so in the moment. Oh, do you know what? I was talking to Bradley Viner. He's like really pioneered all this kind of emphasis on the skills of being a GP vet, and hopefully we'll have him on the show at some point in the future. It's a really big thing because he made the point to me when we were chatting that yeah, a vaccination is an injection. So I suppose we go, oh, new grad can do all the vaccinations, easy. That not isn't really the point. Yes, obviously we do the injection, but that vaccination consult is a really important part of how we build trust with our client. And for me, I go even further because for me, it's going to sound really waffly and weird to most people, but for me, it's about aligning our values. They understand what my values are. I'm understanding what their values are. I'm understanding them better as people, and we're building trust together. Because for me, that's the root of the trust. Is we've suddenly got similar values. They understand that what I'm doing and what my perspective is on how I'm treating their pet. Now, we'll come to how I do that in a vaccine consult, but I'm 100% sure that when that that client leaves that vaccine, the vast majority of them will have suddenly be like, I trust that guy. I really like him.
Mm.
My values are aligned with him. He understands me because I've now put across how I like to be with my pet. And when their patient is poorly in the future, they are a million times less likely to be upset, be resistant to what I'm trying to talk to them about, and complain if things don't go well because I've built that trust in that vaccine injection.
Yeah. It's like if you go to the GP and if you get, like, it doesn't really happen anymore, but I always used to find when I was younger, I had a family doctor. So I'd go back to the same GP every time and you'd have a little bit of small talk at the beginning. It'd be like, oh, how are you? How was that? How was your holiday? Blah, blah. Because they remember you and they know you personally, you build that trust. So when you go back again, they tell you something, you're like, yeah, it's gospel. I'm going to take it because you trust them and you've built that bond. And I think we forget that that's so important in veterinary. People, not only are they entrusting us with their animal safety, but they're paying a lot of money to listen to what we have to say. So we should be really taking the time and the effort to sort of put the time into those consults and give clients the opportunity to ask the questions that they have and to really do the best for that animal in that 10, 15, 20 minutes that we have, really. So I mean, I think for me in a vaccine consult, it's definitely very patient and very client dependent. Some vaccine consults, you can tell the owner is like, I've got half an hour before I've got to get back to work. They come in, they're like, cool, bish bash bosh. Then they don't want any small talk. They just want to be done. And those ones I'm like, cool, do it quickly, do what I have to say, out the door in 5 minutes. And that's what they want. And that's what makes that client really happy. You do what you can for that dog or a cat as quick as you can, but they want to be out the door. Whereas some people want to chat, they want to ask you lots of questions. And especially if you've got a nervous dog versus a really happy waggy one that wants to like lick your face, then again, I'm doing two very different consults because the nervous one, I'm going to be doing a lot more hands off, make my examination super quick and then keep talking to the client. Whereas my happy waggy tail dog, I'm going to be on the floor with it, giving it a good stroke while I'm taking a history, then do my exam, and then go back to stroking it again because that's what makes that dog happy. Do you see what I mean? So they're very different depending on the patient and the client that you get. Do you find the same?
I love that because yeah, it's a vaccine consult, but I bet you, yeah, it's done a million different ways. That's
Yeah.
and we don't really get to talk about this, do we? Because no one goes, "Oh, how do you do your vaccine consult?"
Yeah. Yeah.
Literally no one.
I only ask because everybody else finds it boring. We're probably getting everybody switching off.
Yeah, well, yeah. Yeah, but all the problem, the BBC Panorama, all the
Yeah.
stress, all the and
Yeah.
suddenly, I don't think you're gonna get any of that. Because the
No.
other problem that has gone over this is, and look, I understand like vet practices are businesses, and there will be managers obviously that are like, oh, this is our opportunity. Are they doing routine parasite control and da di da di da, and and so then you're getting them on the health plan. So there is an element of sales about it, isn't there? But that
Yeah.
unfortunately takes away from how the client perceives us. And we have to remember that if we don't tread that line really carefully, they perceive us as, well, all the horrible things that people say about us now, like money grabbing and all of this.
Mm,
Now I don't think any of us vets are thinking that when we're trying to get our
no.
owners to do routine flea and worming, because we see all the harm when you don't get it right. But
Yeah.
owners' perception is that. So we have to be really careful how we see ourselves
Yeah.
perceived, because then they come in 3 months later and their pet's ill and we go, "I wanna do a blood test," and they're like, "Oh, there's that vet that wanted me to do flea and wormer every month," and, even though it's totally right, doesn't matter that they're wrong, they're perceiving
Yeah.
us
It's
wrongly.
it's so true, isn't it? Because I think, like, in a lot of my young animal consults, I'm talking about neutering if they haven't already, and then I'm talking about dentals because a lot of them, their teeth are horrendous. So I'm talking about scales and polishes and things like that. And then in the older patients, I'm talking about mobility. I'm talking about whether they want to consider trialing any medicines or hydro or anything that might help them. You might even be talking about any geriatric patients or anything that's on long-term meds, have they thought about routine blood testing, etc., which are all things that are really good for us to be discussing from a medical point of view. And in terms of the benefit for that patient, we should be discussing it. But it is that fine line, isn't it? Because you're saying, well, I kind of want to discuss this with them because you feel like it's best for the patient. Like if you've got an old dog that's getting a bit arthritic, you want to be able to talk to them about starting them onto medication. Or if you've got a cat that's getting a bit older and has lost half a kilo since you've last seen it, you're like, I'd really like to take some bloods. But then you've got to convince someone to pay an extra 150 quid then when all they wanted was to come in and get it jabbed. So I don't know, it's hard, isn't it? But I think, again, it's about reading the client, isn't it? And I often find myself saying, look, being honest with you, in an ideal world, this is what I'd recommend at this point. Let's say Fluffy, I don't know, it's like a 13-year-old cat. I'd be like, if you want my honest opinion, lots of older cats can get diabetes, hypothyroidism, etc. So it would be kidney disease. So it would be really good to just get a bit of a baseline blood panel just to double check everything's working okay and that we don't need to change anything as she gets a bit older. But but that is going to be, I don't know, say 50 quid. So if you're not ready for that at the moment, then you can keep it in your back pocket. And if you do decide to do it, then go for it. But at least you've offered it. And then they feel like, well, she's not desperately trying to sell it because she's like, do it if you want to, don't if you're not. I'm not that bothered. But I just feel it's definitely a discussion we should have, because then you get the occasional people that come in and say, well, I only came in 2 months ago and it was never mentioned. Or do you know what I mean? So I think it's something we should be discussing, but you've definitely got to like filter what conversation you're having and how you're having it based on who you've got in the consult room with you. So I think generally just bringing it back to general vaccination consults and what we should be aiming to do. I mean, you're just over like when we're talking about anything, doesn't have to be specific, but the main things are you're just trying to build trust. You're trying to build trust with that patient. So make sure that the dog isn't really shit scared of you next time it comes back in, and you're trying to build a bit of a bond, or the cat. You're trying to build trust with the client. You're trying to do your full clinical exam and do things medically to the best of your ability. Are they painful? Do you think they've lost weight? Are there things that you should be picking up on that you think they're more unwell than the owners realize and you need to do something? And basically, you just want everyone to have a positive experience. And if you can, however you do it, there's no right or wrong, is there? Everyone's going to do it differently because everyone's got a different personality and will explain things in a different way. I think, to be honest, I even change it depending on the area that I'm working in because people are different. So I don't think there is a perfect consult in the end of the day. It's just whatever works best for the people that are in that room at that time. Does that make sense?
Yeah, you touched on something I think is really, really important, and that's positivity to the client. I love that.
Mm,
And I will definitely try and work that into every one of my vaccine consults because
mm,
ultimately, the way I look at it, because I've got the lowest expectations because I've just worked in the worst places. If they're coming in for a routine vaccination, they're already like, you're amazing. And I will, so I will focus on all the great things they're doing and say, that's
mm,
brilliant that you do that. That's brilliant. That's excellent. Da di da di da. And a
mm,
lot of my clients will, I think, come out feeling puffed up and really like, oh, I'm doing a good job. You know?
mm.
I don't know, is that am
No,
I
I
think
think,
but I'm trying to motivate them to kinda go, "Take your pet's health
yeah,
seriously. You're doing so many good things, and maybe you
yeah,
can do this extra one too," or, or just
yeah,
empathise with them and go, "Oh, that's really hard to do. Yeah, it's really hard to brush your
yeah,
dog's teeth. Don't worry, he's so
yeah,
nervous." I totally get where you're
yeah,
coming from. Just
yeah.
empathise with them and be positive. That's such a big thing.
Yeah, exactly. Exactly. It's like if you're talking about weight. I mean, I don't know about you, but I tell like
Oh, love that.
90% of my consults, I tell them that their dog or their cat is overweight. It's like a pandemic. I feel really bad because a lot of people I'm having to go, you do realize your cat is morbidly obese. And I will say it in those
Ooh,
terms, but I'm like,
wow.
I understand how it
Gosh.
happens, and I say I know it's a labor of
You
love,
say,
and
"I
that's
was
where it's
morbidly
come
obese
from.
once."
I should do that. Yeah. But I mean, even though I'm trying to come across from the professional side of things and say what I feel I need to say, I'll always bring it back to like, oh, she's still carrying her Christmas weight, is she? Or like something to make it a bit more
Yeah.
lighthearted. Because it's like you say, you want it to feel positive. You don't want people to feel like they're doing a really crap job. Because, like you say, if they're coming in for, especially for cats, if they're bringing them in annually for their vaccines, they're doing better than the majority of cat owners in the UK already. So, it is just about that positivity, isn't it, at the end of the day?
Yeah, and, yeah, I have a little way that I do. We have a pet for psychological reasons, and if we don't acknowledge that, we're missing something. And one of
Mm.
the psychological reasons people have a pet for is because they enjoy they're feeders. They enjoy seeing
Yeah.
their pet enjoying their food. There's other reasons we have pets, but that is quite a big one, and it's biological.
Mm.
It's inbuilt into mammals or, I don't know, everything, insects probably. So if we take that away from that client by feeding it some low-fat diet food, of which who knows how much evidence there really is for benefit. But anyway, maybe there is. But, yeah, I think then there's a problem. So I don't know. There you go. That's me.
Okay, so I guess that's sort of our take on what makes a good vaccination consult. And like we say, it's going to be different for everyone. What we'd like to do is in our next 2-week takedown in a couple of weeks' time, we'll just touch on what vaccines we should be giving and when in dogs and cats. And I know for a lot of us that's going to be really simple, but especially for any of those students or new grads listening, that might be really helpful. We'll touch on the WSAVA guidelines versus what the data sheets say and what we should be doing in practice. But in terms of sort of today's pod, just a little roundup. We've covered loads, and you've probably if you've got to this point, you've done really well for listening to us drabble on. But we've talked about routine neutering techniques in our female cats and dogs, lap spays, subcut ketamine, and we covered sort of what's going to happen in our normal vaccination consults.
We hope as ever you enjoyed listening, and remember to get in touch if you have any comments, suggestions to improve the pods for you, any topics you particularly want to cover.
Thank you for listening. Join us again next Sunday for our next bonus episode where we'll be taking another clinical deep dive, but this time into vomiting in dogs and cats. Until then, it's bye from me.
And bye from me. Take care. The content presented in the Chatty Vets podcast is intended for licensed veterinary professionals and is for informational purposes only.
Views expressed are those of the host and guests and do not substitute for clinical judgment or individualized patient care.
Drug dosages, protocols, medical advice discussed should be verified against current literature and manufacturer's guidelines.
Us and its creators are not liable for any errors, omissions, or adverse outcomes resulting from the application of this information.
Always consult relevant laws, regulations, and institutional policies in your practice. Listener discretion is advised.